Warm good morning and welcome all of you to the Phacoemulsification Toolkit IC. Our first speaker is Dr. Manasa. Dr. Manasa is working as a cataract surgeon at PRS Hospital and at Geethanjali Hospital in Trivandrum. And today she'll be speaking on the topic navigating cataract surgery with concurrent medical conditions. Over to you, Dr. Manasa.
Thank you, ma'am, for the introduction. Good morning, respected seniors and dear colleagues. So let's see how we maintain our perioperative checklist in patients with systemic comorbidities. So the recommendations in the presentation are sourced from the following professional bodies. Now, cataract surgery is an entirely elective procedure. So why can't we just postpone the surgery until the patient recovers systemically? So this statement is neither absolutely true or false, and how do we decide on that? So most of our patients are elderly and many of the systemic conditions can't be fixed easily. And there is a lot of evidence that suggests that waiting for more than 4 months after a cataract surgery is clearly indicated is associated with an increased risk of mortality. As we all know, visual impairment affects the quality of life, increases the risk of fall and fractures, increased hospitalization, nursing home placements, social isolation dependency, and visual and cognitive impairment, and a generalized increase in higher mortality. So let's see a few case scenarios. This first one is about a 57-year-old gentleman with stage 5 chronic kidney disease who underwent a recent renal transplantation, and he's on dual antiplatelets and anticoagulants for a graft renal artery thrombosis. Preoperatively, his blood pressure was 180/100. A medical clearance was obtained, and he was posted for clear corneal phacoemulsification under topical without stopping any of his medications. Intraoperatively, he had a high blood pressure for which a short-acting vasoactive was given, and there was a period of postoperative hypotension. Now let us see what the recommendations say to manage such a case. Regarding hypertension, the recommendations suggest we postpone the elective cataract surgery only if the blood pressure is more than 180/110, and in cases of malignant hypertension where there is evidence of target organ damage. And there is no recommendation that suggests that we should record the blood pressure on the day of surgery, because that will be mostly erratic due to anxiety. And if we give a hypotensive agent based on that blood pressure reading, most likely the patient will go to hypotension, and a mean arterial pressure less than 65 for a longer time has a higher risk of myocardial and kidney injury. Now coming to the recommendations on oral antiplatelets and anticoagulants, we can continue dual antiplatelet therapy and all the oral anticoagulants and the vitamin K antagonist, as long as we are planning for a clear corneal phaco under topical or subtenon block. But we should avoid sharp needle blocks in these patients. And if you are planning to block, we have to stop the drug based on the duration of action of that drug. And a routine heparin bridging is no longer recommended. And the second case scenario is about a 77-year-old gentleman with a host of systemic comorbidities and 2 episodes of anaphylaxis following attempted cataract surgery. He also has a non-healing ulcer in the right leg. So the first episode was following application of moxifloxacin and nepafenac on the day before the scheduled surgery, following which he developed respiratory distress and required an ICU admission. The second episode was after application of dilating drops, again similar ICU admission and treatment for anaphylaxis. So at this presentation, the allergy and immunology department has advised us to instill topical medication only in a setting with resuscitative facilities, and they also deferred an intradermal allergy testing due to the severe risk of anaphylaxis. So in patients with multiple drug allergy, that is to multiple topical medication, it is most likely to the preservative in the medication than the primary drug. Nevertheless, we should avoid all previously implicated drugs, and we should use preservative-free medication and avoid preoperative topicals. Consider a no-drop protocol wherever possible. Use an intracameral preservative-free dilating cocktail, or we can resort to mechanical dilatation, and we have to perform the surgery only in a fully monitored setting in the presence of an anesthetist, a crash cart, IV epinephrine, and we have to secure an IV line preoperatively in all these patients. And the second part of the case, where the patient had a chronic leg ulcer. Now, all the recommendations suggest we have to defer the elective cataract surgery when infections outside the eye exist to reduce the risk of postoperative endophthalmitis. But we should also keep in mind that many chronic low-level infection like an ulcer or a UTI may not be self-limiting and cannot be easily treated, and many of these ulcers are not even infected. So if we are going ahead with the surgery in the best interest of the patient, a thorough counseling has to be done and a high-risk consent to potential additional risk has to be taken. The third scenario is about an elderly female with complete heart block, a permanent pacemaker in situ, with a recent history of CAD, and she's an uncontrolled diabetic. Let's see what the recommendations say for such a case. Regarding the cardiac implantable electronic devices, there are multiple such devices, of which the pacemakers are what we encounter commonly. In phacoemulsification, we don't use diathermy, so a CID malfunction is extremely low. And if a diathermy is used, it can result in malfunctioning of these devices, resulting in loss of cardiac output, life-threatening arrhythmias, and even death. And regarding pacemakers, no reprogramming is needed for clear corneal phaco without cautery. Now, coming to the recommendations regarding diabetic patients, none of the recommendations say that we have to measure the preoperative HbA1c or a preoperative point of blood sugar measurements on the day of surgery, as long as the patient is not unwell, he has not skipped any meals, or he has not skipped any medication. And we can continue all the oral hypoglycemic and insulin, as we are not asking the patient to come NPO. Maybe we can consider stopping the SGLT2 inhibitors, because under stress, it can precipitate a euglycemic diabetic ketoacidosis, which we miss if we don't measure urine ketones. And the third part of the scenario, the recent cardiovascular problem. So the American College of Cardiology and the American Heart Association recommends that if the patient has underwent a percutaneous coronary intervention without a stent, a non-cardiac surgery can be scheduled after 2 weeks. And if it is a bare metallic stent, that is not a drug-eluting one, then we have to wait for a month. And if a drug-eluting stent is implanted, then we have to wait for 3 months for a non-cardiac surgery. And the final case is just a reminder where zero is never a statistical option. A perioperative mortality risk exists even after our low-risk eye surgeries. A 72-year-old female, only known hypertensive, and we plan for a combined right phacoemulsification with pars plana vitrectomy for a macular hole repair. In the perioperative period, she develops loss of consciousness, was brought to the ER, multiple episodes of ventricular fibrillation happens. After multiple cycles of CPR, return of spontaneous circulation was achieved. A coronary angiogram was done, was normal to rule out CAD. MR brain was normal, that rules out stroke. So even on the way to ICU transfer, she gets multiple ventricular fibrillation. And again, many ECGs were taken and reviewed. And finally, she was diagnosed to have Brugada syndrome, which is an occult cardiac channelopathy, where we get a particular kind of wave only in V1 to V3 leads, and that too in a few ECG. Unfortunately, we lost the patient. So this is a reminder that even when eye surgeries have minimal physiological stress and there is no blood loss or fluid shift, a risk of mortality of 0.014% exists, and it is unlikely that this risk can be further lowered. So when to defer to allow the optimization of these comorbidities? So as we discussed a recent CAD, significant arrhythmias, heart failure, acute pulmonary neurological condition, malignant hypertension, and decay. These are what the recommendations suggest. And what are the preoperative tests recommended? Actually none. Not even an ECG or a urine routine examination is recommended for patients who are asymptomatic, but we should carefully document their medication history, allergy history, and the systemic illness history. Now, how long does a preoperative medical assessment is valid? There is no specific time cutoff, as long as the health status, medication, and the allergies is not changed. But it's better to aim to schedule the surgery for a few weeks after the assessment and not more than 3 months. And which cases we need an anesthesia colleague? Only in grade 4 ASA patients, that is where we defer the surgeries. And if optimization is not possible, then we proceed in the best interest of the patient in the presence of the anesthetist. And of course, if you're planning for GA or IV sedation. So the take-home message is, regardless of the elective nature of cataract surgery or the severity of the systemic comorbidities, the decision to and the timing of the surgery should be based on the patient's best interest. The guidelines and recommendations helps reduce unnecessary preoperative cancellations. Thank you.
Thank you, Dr. Mansa. It's actually a very relevant topic because most of our patients are quite elderly. They have multiple systemic comorbidities. And this particular case that she spoke about, Brugada syndrome, actually that patient developed this cardiac event. One of the factors that was proposed was that the patient had to be in a prone position. So that might have been a stress for the patient to develop the VF actually. So we still don't know because even the bystanders and all of us were a little surprised because she was a healthy patient and post surgery she had this event. Thank you, Dr. Mansa. Our next speaker is Dr. Vinita Ramnani. Madam is a well-known person in the national circuit. She currently works as the HOD of the eye department at Bansal Hospital at Bhopal. And Madam is Central Zone Executive Member of the GSI, and she was the organizing secretary of the annual conference of GSI at Bhopal. And Madam is currently the Vice President of MP Ophthalmic Society. She's a recipient of several awards, the Ecoin Oration Award, the BOA Gold Medal Award, Sadhguru Medal, and a lot of other awards. And she's also held various positions such as Chairman Scientific Committee of the KSOS, and she's been the Secretary of the Secretary and Vice President of the Bhopal Ophthalmic Society. She has a very large work experience of more than 30 years, and she's performed more than 30,000 eye surgeries. A warm welcome to you, Madam. And Madam will be speaking on the topic management of coexisting glaucoma and cataract.
Thank you for such a wonderful intro. And I should be thankful to the whole society, Dr. Bastin, Rakhi, you, and many others sitting over here. And it's my first visit to this place, but then I'm really amazed the kind of a scientific content and the hospitality you have been given us. Thank you so much. So let's talk about how to manage coexisting cataract and glaucoma. So we know that the cataract and glaucoma, they can coexist because most of them are elderly and they can have the diseases together, and they can they can affect the diagnosis as well as the management of each other, and it becomes sometimes challenging because there is no definite guidelines led by the society, but then definitely you have to treat such patients either by continuing with the drops and doing only the phaco, or you may require two separate procedures, or you may require a combined surgery. So let's see how we should proceed, but definitely it is individualized. You have to see the amount of the cataract, you have to see the severity of the glaucoma and the individual need of the patient, and so also the experience of the surgeon. Sometimes we just wish to perform only cataract surgery to get rid of glaucoma, especially if it is early angle closure glaucoma, ocular hypertension in an early stage, or where IOP may be controlled with the single drug. So we know there is a drop of 2 to 4 millimeters IOP, and then probably the glaucoma may not progress and you may not require any drug. But then definitely there are many patients, especially in India, they are coming late to the diagnosis, and we are being forced to do either combined or two separate surgeries. Now that becomes a real challenge. That depends actually what is the reason why you are performing the surgery. It is the glaucoma or the cataract, or what is the situation of the current glaucoma control, and what is the patient desire. So two separate surgeries, definitely you can do the trap first followed by cataract, or vice versa. But when you do it, two separate procedures, definitely you have to give a gap of 3 to 6 months, and there are challenges in both the scenarios, whether you do the cataract first or you do the glaucoma first. But definitely, if you do the cataract first, probably you will be managing glaucoma like any other glaucoma. But then only thing is you have to be careful about the IOP spikes. But then if you do the sequential surgeries, definitely it is the one that patient has to be taken to the theater twice, but then you are dealing two separate situations differently, and then you are addressing one at a time. So it gives you an advantage. So but in India, probably in our part of country, definitely the people don't want to go to the theater twice with so much of a issues related to finances, the travel and so many other things. Probably combined could be one of the option, but trap, given a choice, if there is no visual immediate requirement, the trap should be done first, especially in the advanced glaucoma cases. But make sure that tell the patient that you are not going to gain any vision out of it. It is just to control your intraocular pressure, and you might have a progression of the cataract which we need to remove later on. But definitely when you do a cataract surgery, then you have a lot of challenges, and because of the cataract progression, probably you have to do the surgery even earlier than 3 to 6 months. So you have to be prepared for it. And we can see that so many blabs are there, the non-dilating pupil are there, even the biometry is difficult. So there is a risk to the blab when you do cataract surgery following a trabeculectomy, and you may see lot of conditions where you have a weak zonules, you have a raised intraocular pressure. So definitely you have to be careful about managing the complications, and it's a bit of a challenge operating a cataract, which we routinely do. But then if it is because of the post trabeculectomies eyes, you have to have something in mind that this blab should not fail. There is definite 30 to 40% risk of a blab failure because of the inflammation, because of the scarring, because of the blab touch. So probably I am in a favor of doing a combined surgery, and it gives me an option that yes, you can combine it with the trabeculectomy, with valves, with non-penetrating procedures, with MIGS, and even cyclophotocoagulation. So you have lot many choices, but then over the years it has been seen that there's a lot of shift to the Phacoemulsification. So most of the time it is not only the cataracts we are doing MIGS together to get the burden of the medicines over, or maybe sometime you can very well control, especially the mild to moderate, not very fast progressing glaucomas with MIGS Phaco very well. So it's individual choice. If you are being trained into MIGS, you are into MIGS, and your patient is affording, you can go for various stents. But then definitely the many other procedures which doesn't cost you much could be a part and parcel of your cataract and combined procedure to deal with the glaucoma. Definitely the patient prefers this because there is a risk, there is a one visit to the operation theatre, and even the finances are less with this. They recover faster in comparison to the two procedures together, and there is no risk of an IOP spikes which will happen with the cataract surgery alone. So less trauma, more comfortable, better cost of factor relationship makes this procedure a choice by the patient. But you should also saying the disadvantages, that you will require a longer recovery time, you require a longer operating time, and there could be unpredictable results because the phaco is a wound which is self-sealing and it's airtight, and blab of a trabeculectomy, if you are doing a combined phaco-trab, it's a leaky bleb. So you have to be very careful that you have a window which does not give you a shallow anterior chamber and hypotony in the immediate post-operative period. So it is a bit challenging when you perform two surgeries together. Let's see whether you do a combined phacotrabeculectomy through the single site or the two site. Single site is little bit challenging. We started with single site, but eventually every one of us now has shifted to the two separate site, doing a corneal clear phaco like any other phaco and trabeculectomy at 12 o'clock 12 o'clock like any other trabeculectomy. So both has their own advantages and disadvantages. If you do a single site phacotrabeculectomy, probably you are saving the time. You don't have to position yourself. You can sit at one place and in a single go you can do both the surgeries together. But definitely there is a lot of inflammation because you are going through the same port. There will be more handling, and there's always a risk of mitomycin going through that port when you do a cataract surgery first, and then you are applying the mitomycin. So you have to be very, very careful that mitomycin has to be used before entering into the anterior chamber. So I will show my video that how I started my phacotrabeculectomy, and I did it for years, and I was really enjoying this because there was nothing extra I was doing, but then I was offering a good control, especially for my charitable patients where I worked for 13 years. So you go for a single site phacotrabeculectomy, make a scleral flap, continue your phaco procedure through the same tunnel, and then you finish off your phaco the way you are doing, and then you inject the lens, and after injecting the lens you can cut open the inner window and do an PI. So that becomes much easier, faster. But nowadays, because we are not doing a scleral phacos, we are more into the topical clear corneal. So this becomes sometime a challenge, but then it used to be a very common procedure in our trust hospital, where we used to have lot of glaucomas coming from the periphery, and it used to work very well. It used to control intraocular pressure. Only thing is it requires little more recovery time. So you don't expect the recovery to happen in 2 weeks, 3 weeks time, but it may take 6 weeks to recover and stabilize the refraction. But definitely a very fast procedure and good control of intraocular pressure. But then nowadays I told you that my preferred approach is do the clear corneal phaco and do the trabeculectomy separately, so that you can do the justice to both the procedures the way you want to control the intraocular pressure, especially with the deep-seated eyeballs. When you have that very narrow working space, definitely this procedure works very well. So to summarize, we have the whole picture, starting from the ocular hypertension to a very advanced glaucomas and various types of secondary glaucomas. So they come across with the cataract together. What will you do? The protocol is like when you have an ocular hypertension or you have very mild glaucoma, which is either angle closer or angle open, probably the cataract extraction alone can be an choice, but keep a strict watch on the disc field and the IOP to see what is happening to the glaucoma over the time. But if it is moderate, definitely you have to do something to control the intraocular pressure. You can do a combined procedure, which is really loved by the patients. You can do MIGS, so mild moderate glaucomas, cataract with MIGS is one which we are looking into, making the patient drug free and making the patient happy that glaucoma doesn't progress, and it's well accepted. But in advanced glaucoma with a very mature type of a cataract, a near mature cataract, becomes the challenge, because now you have too many things to tackle. So you can do a combined phacotrabeculectomy, and two separate site phacotrabeculectomy is really one which we have been doing for years and years, because MIGS probably in advanced glaucoma you have to give additional drugs. So I think trabeculectomy, if you can nurture your bleb, and if you are not worried about these post-op complications, you have to go for the two separate site combined phacotrabeculectomy. And if it is less cataract, doing two separate procedures depending upon the severity. If it is very advanced glaucoma, I will prefer doing trabeculectomy first and then cataract later on. And in secondary glaucomas, it is always good to have two separate procedures, because a lot of inflammation and many other things, that scarring and the bleb related issues in secondary glaucomas, it is preferred to have two separate surgeries rather than combining together. But in overall, it depends upon the patient's choice. like if the patient is ill, especially in multi-speciality, very old patients with multiple cardiac or another issues, probably there is a chance for doing the combined and looking into the blab that it should survive. So there is controversy, but then it's good to individualize each case. Thank you so much for the patients listening and having me here. Thank you. And I will request just to vote for me for member scientific committee. I'm from Bhopal, Madhya Pradesh.
In case of SACs is study, like related to some medication, if you have to do SACs and study function, will you prefer a single site or
I think it is always good to have two separate sites because SICS wound is little bigger, so you wanted to have that tight closure which you were offering by doing a phaco because the tunnel is smaller. But then if it is SICS, the tunnel is little longer and bigger, so probably there's a more risk of leak. But then in Trust Hospital, I did a lot of SICS trap and it's really worked well. But then now, over the years, we have learned that the minimal or smaller is good for our eyes.
For sharing your vast experience and making things clear for us. If there are more questions, we can take it towards the end of the session. Madam will be there with us.
Our next speaker is Dr. Ambika Shetty. She is the Medical Director, Cataract and Refractive Surgeon at Geethanjali Eye and ENT Hospital, Thiruvananthapuram. She will be talking about taming the floppy iris, and also she'll be sharing essential tips and tricks for IFIS cases. Over to you, ma'am.
A warm good morning to all of you. So, is this floppy iris situation a challenge for you when you operate? Yeah? Yeah. So, it's usually in the beginning stages of my career, I have encountered it intraoperatively, and that is when I've always reflected and thought, oh, I should have been little more careful with the history. So, that is why I wanted to present this topic here. So, we know that intraoperative floppy iris syndrome is characterized by the triad of iris billowing, intraoperative meiosis, and iris prolapse through the phaco and side port incision. Most common cause is that the patient is on alpha-1 blockers. So, especially the medicine that is tamsulosin. Tamsulosin has the highest affinity for alpha-1 blocker. So, this history is very important. So, even if you have missed, it's important to ensure that your counselor has it on her checklist. So, please do not miss this history. Majority of patients, they may think that some of them may be aware, some may not be aware, they might not have been counseled, that they may tell you all other histories but not the history of alpha-1 blockers. So, sometimes even ladies are on these medications. So, please be careful and take a history and ensure that your counselor takes the history as well. So, compared to the Indian and overseas population, more Indian population, that is almost 4.7% of patients are on alpha-1 blockers, and compared to overseas it's only 2.3%. Actually, if you see the statistics in Kerala, much more people are on alpha-1 agonists. In our practice, we see that at least 1 in 20 male patients or sometimes more are on this medication. So, the complications may be as simple as iatrogenic iris injury. Sometimes it may be PC rent, vitreous loss. Sometimes very severe complications, hyphema, iridodialysis can also happen. So, we should always be, we should anticipate this condition and be prepared for that. If you want to classify the severity of IFIS, it can be mild when it is characterized by only iris billowing, moderate when there is iris billowing and either meiosis or prolapse to the side ports and main incision, and severe it is characterized by all three features, that is iris billowing and meiosis and also prolapse through the main and side port incisions. It's important to understand in your preoperative examination what is the exact dilatation, what is the maximum dilatation that the patient achieves. So as I said, it's very important to take the proper history, examine and have a standard protocol to manage this condition. So when you start your surgery, ensure that the length of the incisions is adequate enough. So the main incision should be at least 2 millimeter long if you are anticipating a case of intraoperative floppy iris syndrome. Also, you should make sure the entry is anterior to the iris root. Please ensure that, yeah, I had paused it. Yeah. So please ensure that the rex's size is adequate so that all your procedures are comfortable. And when you are doing the hydrodissection, please be gentle, because many of the times we see that the prolapsing starts during the hydrodissection itself. And once you start the phacoemulsification, depending on what is your technique that you are comfortable with, either it could be a stop and chop or a direct chop, whatever you are comfortable, you can do that. In my case, I would prefer a direct chop in case of IFIS, because you are injecting lesser fluid below the level of the iris. So that is why I would prefer a direct chop. And also you should ensure that when you are emulsifying the nucleus fragments, it could be slightly above the plane of the iris, so that you avoid the fluid currents going below the iris and minimize the possibility of the iris prolapsing out through the side ports. Also, which viscoelastic to be used in such cases? It's important to use a viscodispersive viscoelastic. So this will also tamponate the iris down and ensure that it is away from the wound margins. So in case you have an iris prolapse such as this, you go to the main port and then reposit the iris back and then go ahead with the surgery. So preoperatively, you can use medications such as atropine eye ointment 1%. You can use atropine drops or homatropine or cyclopentolate drops. Also, NSAIDs are preferable. In my case, I use homatropine drops for 2 days before the surgery. And intraoperatively, you can use drugs such as phenylephrine, lignocaine and adrenaline to maintain the intraoperative mydriasis. And ocular OVDs, as I said, you can use, it is a must to use dispersive viscoelastics. You can also use a combination of dispersive and a adaptive viscoelastic. In certain cases, you start off with the surgery, the pupil is well dilated, but as the surgery progresses, you notice that the pupil starts becoming smaller. In such cases, it's better not to hesitate. Go ahead and place a mechanical expansion device. In this case, I have used the BHEX device. Apart from giving a mechanical dilatation to the pupil, it also ensures that it reduces the billowing to some extent. So it's a very relevant in a case of IFIS. Even if you have a medium dilatation, if you use a mechanical expansion device, it will definitely make your surgery much simpler. So in some cases, the nucleus is very hard, and you may not be able to get maximum dilatation with the mechanical expansion device. So you can also go ahead and use iris retractors, iris hooks. So in this case, the nucleus was very hard, so I've used iris hooks, and also I've performed a SICS for this patient, because this would have been more appropriate for that particular patient. So it's also important to take that clinical decision depending on the preoperative dilatation. If the pupil is very small, then you can go ahead with the SICS procedure as well with iris hooks. So it's important to anticipate IFIS before surgery. As I said, it is important to ensure that this is always mentioned in your checklist. Even if you miss, make sure that your counselor has taken the history whether the patient is on any medication that can precipitate IFIS. And it's important to take preoperative prophylaxis so that you are well prepared. And OVDs should be used appropriately to prevent iris prolapse. Hydrodissection and hydrodelineation are two maneuvers which represent more risk of iris prolapse. So you should be very careful during these procedures. Thank you.
Thank you, ma'am, for sharing your tips on management of IFIS cases.
It was nice presentation. I think if you lower the intraocular pressure by giving Diamox before, it will help reducing the risk of iris prolapse. What is your say on this?
Personally, I am not using Diamox, so I don't know the difference. But if during the procedure I feel there is more of thrust and positive pressure, I would reduce the bottle height and reduce the parameters.
So you now next time you give the Diamox and see, because I have started giving Diamox, especially not only in this iris floppy iris syndrome cases, but the cases where the pupil is not getting dilated, or when the blood pressure is on a little higher side, or if the patient is anxious, if the patient is having fat and it's short neck. I have started giving Diamox to such patients and I felt the difference. So it gives you a little lower intraocular pressure during the surgery, and you are manuring, especially with the shallow anterior chamber and the iris coming again and again. I think if you reduce the intraocular pressure, the manuring become much easier. That's what my personal feeling. What's the house says on this?
Yeah.
I give 250 for all cases on the morning of surgery.
Okay. I think that's a useful tip. I can try. I'll definitely try it for my next patient.
We never give Diamox
Yeah.
usually, but then all my high risk cases I make sure that I will give the Diamox. I
Okay.
don't know it's giving me mental satisfaction or really.
What about injection mandatory?
That's true, but then it doesn't work immediately. You are going to finish up in surgery in 10 minutes, and by the time when it all starts working, you will be over. You can give pre-op.
Yeah.
But then you have to take IV and everything. So giving the Diamox, like patients, sometimes they are a little bit worried about the pricking. So that's why I took that Diamox as in 1 hour before the
Cardiac patients, I think you should give molasses also along with it. Otherwise, patients having heart failure and all that.
Yes, definitely. That even that sulfa allergy and everything you have to take care. That the routine protocol for Diamox, you have to see whether that Diamox you can give it or not.
And you have to anticipate diagnosis also.
Yes.
So thank you. We move on to our next speaker. Our next speaker is Dr. Raki. Dr. Raki, all of you know very well. She's a cataract surgeon, and also she's a very dynamic speaker. She's a part of multiple national and international conferences. So Dr. Raki will be speaking on taming the polar bear, okay, the PPC cataract, which all of us need to be very well prepared and manage well. Yeah, over to you, Raki.
Good morning, everyone. So I'll be talking on posterior polar cataract today. So the objective for this presentation is to recognize why posterior polar cataract has a high risk and to learn some low stress techniques which we can use for the safe management, the do's, the don'ts, and the bailout tips if PCR occurs. So studies report that the chances of PC rent is around 20 to 36% in posterior polar cataract. 26% of them can have a pre-existing defect. This pre-existing defect can be missed if we have a mature cataract and we are unable to see the status of the posterior capsule. So you need to anticipate that there can be a posterior polar cataract in cases that are so mature. If the other eye is unoperated, look for the other eye and see if there is any PPC in that. If the other eye is operated, you have sometimes might miss this. And the another thing is that 40% of them can develop intraoperative defect. While you are doing the surgery, before that there may not be a defect, but doing the surgery, there will be a defect. Because the posterior capsule in these cases are pre-weakened, they are dehiscent. So even the normal forces can lead to rupture of the posterior capsule. So what all we can look for? In the slit lamp, look for a classic onion peel type of posterior polar cataract. But sometimes, many a times, you may not be able to see such a beautiful crystal clear posterior polar type of a cataract. What will be there? There will be some other signs, like there it will look like a PSCC, normal PSCC, but some demarcation and a sharp thick margin will be there. It will look like a PSCC with a centrally little harder plaque, but with some vacuoles nearby. Sometimes it will look like a PSCC only, but some white spots at the edges. Maybe you can see some oil droplet like things or a shining things in the immediate vitreous. Or maybe there is some white dots in the vitreous that will move like a fishtail sign. So, Minimathan sir was telling the last day that in cases of posterior subcapsular cataract also, whenever you see there is a thickened plaque along with the posterior subcapsular cataract, even though it is not looking like a pakka PPC, still you anticipate, you just have in your mind that it might be a PPC and go into theatre prepared. Imaging optional but useful ASOCT. Counseling the most important part. You need to tell that there is high risk of PC rent. It is because of their own eyes pre-existing defect. Chances of vitreous loss. You need to be prepared for an anterior vitrectomy, a secondary IOL, and there can be a chance of NDA capsulotomy later if there is a residual plaque. So the most important pearl coming to managing a posterior polar cataract or an anticipated posterior polar cataract is keep a low bottle height, moderate flow and vacuum, and avoid sudden surges. So in order to avoid the sudden surges, you need to maintain the AC with a cohesive plus a dispersive OVD. Incision standard clear corneal, but ensure that it has a good construction to avoid any leakage or chamber collapse. Fill with cohesive OVD for capsular excess or do a soft shell technique. Capsular excess should be round, well centered 5 to 5.5 mm for a future optic capture if needed. Some of the surgeons prefer an oval capsular excess in these cases. Hydrodissection, the golden rule, gentle hydrodelineation alone, no dissection. Inject the fluid centrally. Like what we do, we normally go to the 4 o'clock and 8 o'clock position, but in this case be central, gently, low, short volumes, watching carefully for the golden ring. Many surgeons prefer multi-quadrant hydrodissection with tiny amount of fluids, and alternatively you can also visco-dissect the cortex or epinucleus instead of the BSS to avoid hydraulic blowouts. Try to keep that epinuclear shell as long as possible. So, we all will be very familiar with the inside-out delineation which was taught by Dr. Afay Vasavada. So what he does is, first he does a central sculpting, only sculpting, little bit of sculpting, and then he takes this bent cannula and does the surgery. Let's have a look at it.
Illustrates that with the bent cannula, you can decide what level, anterior posterior level, you want to penetrate and generate demarcated central nucleus, and you can repeat this on the other side.
So it was a central sculpting first, then taking the bent cannula a little bit inside and then doing
Illustrates that
hydrodelineation. Another important and famous technique is the multi-layer delineation, which was by Dr. Gulani. Here he is going into multiple levels and doing hydrodelineation in multiple levels. So what happens is the central nucleus pops up. So it is very easy to take it out and eat it first. Then you can deal with the posterior plaque later. So the nucleus management, the more common text is inside of delineation, which was progressed by the Vapai Vasavada, modified stop and chop. V chop is there, in which the central sculpting is done in a V shape, and then you eat up the central nucleus and then go for the remaining epinuclear shell. Similar thing is lambda, where the central nucleus is first chopped like a lambda and then go with the central sculpting. So phaco chop always maintain a low vacuum with minimal rotation. Epinucleus also go for a low vacuum and low flow. Pull the material centrally, avoid the stripping forces tangentially. Cortex aspiration by manual IA or a manual dry aspiration with Simcoe. Low blow till height and low flow rate. Pull the cortex tangentially, not centrally. Avoid polishing because this has a very delicate posterior capsule. Whenever there is a dense posterior plaque, don't try to be a hero. You can treat it later with the ND-YAG capsulotomy. So this is one of my videos on how I deal with posterior polar cataracts. So I usually prefer the multi-layered, multi-quadrant hydrodelineation. You can see there is 2 rings, and I don't rotate, only the central sculpting in the V-shaped manner. Then usually I use the second instrument a lot. Along with that, I do this remaining layer by layer phaco. And for the posterior plaque, I usually keep it towards the last. Aided by the second instrument, I lift it up into the central AC and then eat it up. Then sequential epinucleus removal. All to be done under very low parameters, and make sure once you are removing one instrument, always inject visco, because you don't need the AC to be, you need the AC to be maintained throughout the surgery, and avoid polishing in these cases. So just to reiterate, don't perform routine forceful hydrodissection, don't aggressively rotate the nucleus, don't strip the cortex vigorously, and don't do polishing. And don't let the anterior chamber collapse at any point of time. Slow instrument exchanges, OVD refill before removing props. Do have the vitrectomy and sulcus compatible IOLs ready. So if you have a PCR, early recognition is the best. Immediate steps, we all know, stop the phaco, foot pedal to irrigation only, inject dispersive OVD through the side port to tamponate the rent, maintain the space, stabilize remaining lens material, avoid fishing of fragments. For vitrectomy, perform an anterior vitrectomy with a high cut rate and low vacuum, and use triamcinolone if you need. IOL decision, if you have an intact capsule, place a standard IOL in the bag, ensure good rexis, optic overlap to reduce the risk of decentration and further PCO. PCR with a good anterior capsular rim, go for a 3-piece with an optic capture. Big defect, opt for iris claw lens or scleral fixated lens. So just to conclude, respect the capsule, not the clock. Slow, deliberate surgery is safer than the fast routine phaco. Avoid routine hydrodissection, rely on hydrodelineation or viscodissection. Low parameters throughout, maintain the epinuclear shell as much as possible. Always be prepared for the PC run with vitrectomy and secondary IOLs. And now a simple, safe bailout plan is appropriate for all of us. Thank you.
So thank you, Raki. I think it's your very comprehensive talk. You've covered most of the points about PPC. I just have one question for you. If you have a list of, say, 4 or 5 cases, then which case would you, at what order would you place PPC?
Usually I always keep all the complicated cases first.
First?
Yes,
Okay.
because I want my mind to be clear.
Okay. So will it be like, okay, the other patients will be complaining just in case something happens in the beginning?
That has to be anticipated. We have to inform them.
So you prefer it first?
Yeah, I usually prefer all, especially if PPC is there in list, it will go first if there is no torics.
Okay. What about you, madam?
Same. Any complicated case, any high risk case, any VIP case first. Probably you are more perceptive, you are more prepared, you are into a good mood. And I think if you do very good this case, your whole list goes smooth. Otherwise, when you are doing a normal case also, your mind is always with that high risk
What
case,
is
that
going to
PPC
happen?
case. So it's, I think, individual choice how will you deal with. But then when you are into a theater for your first case, you are more prepared for everything.
Any more questions?
One thing I realized in PPC, like when you are injecting IUL, that time you become relaxed because you think that you did a wonderful job and
So I just need to add one more point. Even at the end of the surgery, you have to give a limited hydration because sometimes the PC can give away when you hydrate too much, even after completing the whole surgery. So you think you have placed the IOL, everything, PPC is done. And when you give a forceful hydration, just hydrating the side port, the PC can give away. So always try to give only very limited hydration in PPC cases. And one more point, like regarding the last question, giving Diamox to IFIS. So I think, ma'am, there are two entities. The iris prolapse can happen due to raised IOP, and it can happen due to tamsulosin also. But yes, like preoperatively, if you are suspecting a raised IOP like shallow AC, or if it's like short axial length cases, definitely it's better to give hypotensive drugs. But normal life is with the normal axial length and no other risk factors, only the tamsulosin factor. I don't think Diamox will give anything extra. But there are two entities, like you are suspecting a raised IOP intraoperatively, that is acute intraoperative Roca-Rey syndrome. So in such cases, you have to preoperatively give mannitol specifically. But otherwise, normal life is due to tamsulosin, Diamox, I don't know, even I don't give it actually.
So one more thing I would like to ask to the group here is, in PPC, does anyone do hydroimplantation? I think it is not preferred, but does anyone do hydroimplantation in case of a posterior polar cataract? Like finally, you see that you have removed the plaque, the PC is intact, there is no rent, but still, I think hydroimplantation is to be avoided, right? Have any thought?
doing a hydroimplantation is risky, but then there are very few expert surgeons are the surgeons at high volume setups. They are into habit of pushing the IOL under hydro. So even I will not do in my routine cases also. It's just the choice, I think.
Yeah, as discussed, at every stage we need to be very careful, as Dr. rightly pointed out. Even during the final hydration of wounds also, I have also had one case where all the necessary steps were taken. Only towards the fag end of the surgery, when you actually relax, hydrate the wound, PC rent. Yeah, it can happen.
And then there are a few surgeons who also recommend using AC maintainers for cases like PPC.
No, it will put more pressure. There will be more fluid turbulence. So I think AC maintainer is not a good idea.
Any questions? Anything to add? Minu ma'am, posterior polar.
Thank you all for your patient listening. We come to the end of the session. Thank you.